Ask the patient to stand and inspect any abnormalities in the carrying angle or if there are any scars, bruises, or swelling. For lateral inspection, note if there is a presence of fixed flexion deformity or the inability of the patient to fully extend or straighten the elbow. For posterior inspection, note for any scars, bruises, or nodules, especially in the area of the lecum and bursa. So after inspection, palpate or press over the lateral epicondyle, the medial epicondyle, and the olecranon process just above the bone of prominence of the elbow. In assessing for range of motion, with his or her elbows flexed, instruct the patient to bend or straighten her elbow, while noting for any restrictions in the movement or any signs of discomfort. Then instruct the patient to repeatedly turn her palms down or up, and if abnormalities are noted on these active movements, you may assess the movements again passively. Additional tests may also be performed to assess for the presence of epicondylitis. Positive Cosen's test is when pain increases over the lateral epicondyle when patient tries to extend the wrist against downward resistance. On the other hand, positive Coulter's elbows test is when pain increases over the medial epicondyle when patient tries to flex the wrist against resistance. For the techniques of examination of the wrist and hands, first inspect the position of the hands in motion for smooth natural movement. Note that when fingers are relaxed, they should be slightly flexed. Next is to inspect the dorsal surfaces of the wrist and hands by asking the patient to pronate his or her hand. Carefully inspect for any swelling over the joints or signs of trauma, and note if it is diffused or localized. With the patient's hand in the supine position, inspect for the palmar surfaces of both hands by observing the contours of the palm, namely the thenar eminence at the base of the thumb and the hypothenar eminence at the base of the fifth digit. At the wrist, palpate the distal radius and ulna on the lateral and medial surfaces. Then compress the metacarpal joints by squeezing the hand from each side between the thumb and fingers. Use your thumb to palpate each metacarpal joint and note for any swelling, bugginess, or tenderness. The anatomical snuff box is just distal to the radial styloid process. Also palpate for the medial and lateral aspects of both distal and proximal interphalangeal joint, again checking for swelling, bugginess, or tenderness. Bouchard nodes and Heberden nodes in osteoarthritis may be common in PIP and DIP respectively. In assessing for the range of motion, instruct the patient to turn her palms up with their fingers pointed toward the ceiling and down with their fingers toward the floor. In a similar manner, instruct the patient to alternately move her fingers toward or away from the midline. Assessment of discriminative sensation is also done. For the median nerve, the stimulus is applied to the palp of the index finger, then to the palp of the fifth finger for the ulnar nerve. The stimulus is likewise applied to the dorsal web space of the thumb and the index finger for the radial nerve. Maneuvers like hand grip test is also performed by asking the patient to grasp your fingers. A positive result can mean weakness of the finger flexors or intrinsic muscles of the hand. We can also test for thumb function by asking the patient to grasp the thumb against the palm and then move toward the midline. For carpal tunnel syndrome, we can test for thumb abduction by asking the patient to raise the thumb straight up as you apply downward resistance. Weakness on thumb abduction is a positive test. Test for Tinel sign is also performed by tapping lightly over the course of the median nerve. In Fallon sign, ask the patient to press the backs of both hands together to form right angles. For the fingers and thumb, ask the patient to alternately make a tight fist or spread the fingers. Abduction and adduction is also performed by asking the patient to spread the fingers apart and back together. Then ask the patient to move his or her thumb towards and away from the base of the fifth finger. and then also ask the patient to move the thumb anteriorly away from the palm and back down again. Similarly, thumb opposition may also be assessed by asking the patient to touch the thumb to each of the other fingertips.
Begin the examination of the spine by observing the patient's posture, including the position of the neck and trunk. Assess the patient for erect position of the head, neck, and back. Drape or gown the patient to expose the entire back. If possible, the patient should be in a natural standing position, with feet together and arms at the sides. From behind the patient, identify the spinous processes, paravertebral muscles, iliac crests, and posterior superior iliac spines, usually marked by skin dimples. Next, palpate the spinous processes of each vertebra for tenderness. In the neck, palpate the facet joints that lie between the cervical vertebrae. Palpate the sacroiliac joint, often identified by the dimple. And inspect and palpate the paravertebral muscles for tenderness and spasm. With the patient lying on one side with one leg extended and the upper leg with the hip flexed, palpate the sciatic nerve, the largest nerve in the body. It lies midway between the greater trochanter and the ischial tuberosity. Next, inspect the neck, including the sternomastoid muscles, for symmetry, deformities, swelling, or abnormal posture. Then palpate the spinous processes of the cervical spine, as well as the trapezius muscles and the muscles between the scapulae. Identify any areas of tenderness. Now test range of motion of the cervical spine. To test flexion, have the patient touch his chin to his chest. To assess for extension, ask the patient to tilt his head back. Note any limitations in range of motion. To check rotation, have him turn his chin to his right shoulder, then to his left shoulder. For lateral bending, ask him to bend his head toward his right shoulder and toward his left shoulder.
For the range of motion, as depicted in the picture, instruct the patient to bend forward and try to touch his toes. Then instruct the patient to bend back as far as possible while placing your hand on the posterior superior iliac spine with your fingers pointing towards the midline. Then stabilize the patient's pelvis by placing one hand on the patient's hip and the other on the opposite shoulder. Then instruct the patient to rotate from side to side. For lateral bending, instruct the patient to bend to the side from the waist while placing your hand on the patient's hip. This movement is repeated for the opposite side. Note for decreased spinal mobility.
Inspection of the hip begins with careful observation of the two phases of the patient's gait. Stance, when the foot is on the ground and bears weight, and swing, when the foot moves forward and does not bear weight. Normal gait has a smooth, continuous rhythm. Most hip problems appear during the weight-bearing stance phase. Palpate the bony landmarks, including the iliac crest at the upper margin of the pelvis at the level of L4. From there, you can follow the downward anterior curve to locate the iliac tubercle, marking the widest point of the crest. Tracking downward, you'll find the anterior superior iliac spine. Place your thumbs there and move your fingers downward to find the greater trochanter of the femur. Move your thumbs medially and obliquely to the pubic tubercle. On the posterior aspect of the hip, palpate the posterior superior iliac spine directly underneath the visible dimples just above the buttocks. Next, locate the greater trochanter at the level of the gluteal fold and place your thumb medially on the ischial tuberosity. The sacroiliac joint is not always palpable, but may be tender. Note that an imaginary line between the posterior superior iliac spines crosses the sacroiliac joint at S2. Then, palpate along the inguinal ligament. Here, the femoral nerve, artery, and vein bisect the overlying inguinal ligament, while the lymph nodes lie medially. The mnemonic navel may help you remember the lateral to medial sequence of nerve, artery, vein, empty space, lymph node. If the hip is painful, with the patient lying on the side and the upper hip flexed, palpate the trochanteric bursa, lying over the greater trochanter, and the ischio-gluteal bursa over the ischial tuberosity, which is not palpable unless inflamed. Now assess the mobility of the patient's hips. First, check flexion. With the patient supine, place your hand under the patient's lumbar spine. Ask the patient to bend a knee up to the chest and firmly against the abdomen. Note when the back touches your hand, indicating normal flattening of the lumbar lordosis. Further flexion must arise from the hip joint itself. Observe the degree of flexion at the hip and knee. Normally, the anterior portion of the thigh can almost touch the chest wall. Note whether the opposite thigh remains fully extended, resting on the table. If the opposite thigh flexes, there may be a flexion deformity of the hip. Next, check extension. Have the patient hyperextend the thigh in a posterior direction. Check abduction next. Stabilize the pelvis by pressing down on the opposite anterior superior iliac spine with one hand. With the other hand, grasp the ankle and abduct the extended leg until you feel the iliac spine move. This movement marks the limit of hip abduction. Next, check adduction. With one hand on the patient's opposite hip, hold one ankle and move the leg medially across the body and over the opposite extremity. Test internal and external rotation of the hip. When this helpful test is normal, hip arthritis is less likely. Flex the leg to 90 degrees at the knee. Then stabilize the thigh with one hand and grasp the ankle with the other. Now swing the lower leg medially for external rotation at the hip and laterally for internal rotation. Repeat each of these maneuvers on the opposite side.